In contrast to this, we get to subdural hematoma. It's in black because it's much worse. And how is it with subdural hematoma? Acute subdural, these acute epidural hematoma, acute subdural hematoma. So typically what you see over here is the moon, remember? Because this is below. Dura is glued to the wall, but this happens below the dura because the bleeding is, and watch out, it's serious bleeding from arteries. Arteries that are part of the brain. It's a parenchymal bleeding, serious on the top. Okay, so there's a laceration of all the vessels, and they just bleed there wildly. Okay, but typically this is much worse, like higher speed, whatever when it happens. So this is a much higher impact, or the impact was much higher for the brain than with the epidural hematoma. And also typically the subdural hematoma combines in many cases with contusions. You can have 3, 4, 5 contusions or none, depends. But this is, you would expect contusion there as well. It's very common, okay? But anyways, we're talking about subdural hematoma focus. Let's focus only on subdural hematoma. So remember, it's a laceration of the brain, and the brain bleeds over there from all kinds of vessels, okay? This is the acute subdural hematoma. And of course, over here, more people die, like 50% and more, okay? And if they won't die, they can have serious neurological deficits in future if they survive, okay? So it's much worse car accidents, whatever, that's subdural hematoma. And it's bleeding from the brain right away. What's the difference over here? It's a big difference in surgery. Because again, if I will draw someone here. Okay, so over here, this is wild. There's a big hematoma. So you open the skull as much as you can. Okay, so typically you're taking the biggest part of the skull you can. Okay, yeah. And there are two reasons, but there's one main one. You're expecting you won't be putting the bone back. Basically, when you're opening a skull because of the subdural hematoma, you know you won't be putting the bone back because what? Over here, there's a huge intracranial pressure which is building up. And if you would open it, if you would make a small hole like in epidural hematoma, guess what? The whole brain would like burst out of this small opening. So that's why you open it widely, that the brain can like sort of get out, but like not be cutted by the edges of the skull, okay? So basically, when you see subdural hematoma, you know that the neurosurgeon will open it widely and leave it without the bone, okay? Leave the patient for a month, typically two, without the bone, yeah? 2, 3 months. It always depends when the edema disappears. So you're opening it with much, this guy looks weird. Like, now it's more masculine, okay. Yeah. After plastic surgery, maxillofacial surgeon came and, the micrognathia improved. Good. We're making a man, now it's a woman, so let's make it. Well, doesn't matter. Anyways, so that was a transformation. Anyways, so you open it widely, but guess what? Over here, and this is a big trick, with the opening, when you're cutting the skin, you will prepare a fascia that's on the top of the skull. So you open the skin, and there's a fascia on the bone. And so you put one layer out, and then you prepare this fascia, okay? So basically, if I'll do an opening here, okay? Here you have a layer of skin, like this, okay? And then you have a layer of fascia that you prepared, okay? And here's a big trick. So you take out the skull, So you do the bar holes, yeah, take out the skull. It's a wide opening. And now you cut the dura, okay? And when you're cutting the dura, you open it, and suddenly what you see the blood. So you take out the coagulums, everything, and suddenly the brain goes out. So when the brain gets out through the opening of the dura, you're not able to put the dura back if there's no space. That's why you prepare the fascia, which is elastic, you can expand it. And what you're going to do is you're going to put something that was on the skull, you're going to use it as artificial part of the dura, okay? So you're putting something you're putting fascia, it's going to be below the skull in future, okay? So what you're going to do, you're going to take this fascia, the red one, after you stop the bleeding, you stop the bleeding on the brain, or take out the coagulum, and then you you seal the opening by this fascia. So you leave the dura like that, and you take the fascia, and you put it here, and you suture it like that. So you seal it with this fascia, the opening, because you don't want the liquid to get out. So use it as a patch, okay? But it has to be supplied by the vessel. So you leave the vessels from the bottom to supply the patch, and you patch it, and you leave it like that. And then you suture the skin, okay? So there's a hole in the skull. Fascia seals the opening in the dura, okay? And then you suture it, and you take out the bone. Because how the patient will look like? Now you will see a balloon on one side where there was a surgery, and the brain goes out. So the person looks asymmetrical. And you can touch the brain like from outside, okay? Through the skin, of course. And now you're waiting. He survived, he's okay, he starts to communicate. 2 months, 3 months before the edema disappears. And suddenly you will see how now suddenly he has no bone here because it's going to fall back. And this is a time when you give the bone back, or nowadays whether you do on a 3D printer, you print something that simulates has the same shape, and you put it there, okay? So, and you put it just below the skin. So you leave the fascia there, as it is in the opening, and you just put the artificial bone or the original bone on the fascia below the skin, and you seal the skin, and so subdural hematoma has 2 stages of surgery. First, taking out the bone, and then replacing it or putting it back, okay? So much more serious surgery. So this was acute subdural hematoma, much more severe and dangerous. And one more comment, and that's a comment on chronic subdural hematoma. And this is something totally different, okay? Totally different in terms of prognosis and in terms of whatever, surgery. So watch out. It's a chronic subdural hematoma. And what is it all about? This one, the chronic one, we could say, and I could agree with pathologists, that this one is mainly due to rupture of a small vein somewhere, bridging vein or whatever. So, and typically happens in older patients, old patients, 60, 70 years. They hit themselves, and suddenly the vessel ruptures a bit. So there's a small bleed, just a small tiny bleed somewhere, subdurally. But what happens, there was a blood. So, and this blood falls into pieces, and this makes it a osmotically active substance. And during months, really months, it's sucking water there. So you have a very slow expansion of a place where there is liquid, okay? Typically, if I will draw a brain again, or skull. So typically in this case, over here, just a bit of blood, and it starts to expand, but very slowly. So what happens is that the brain is able, this is a brain is able to compensate that. So there's a very slow pressure that builds up that works on the brain, and thanks to this, for several months they're totally okay, they're neurologically fine, there is no deficiency, they can walk. And suddenly after 3 months, 4 months, half year, doesn't matter, suddenly what happens? The brain is not able anymore to somehow fight with this shrinkage. It's a shrinkage of one hemisphere actually, the other one is fine. And suddenly the patient now wakes up and is not able to move with one side. So what would you say as a clinician or a family member? It's a stroke. He had a stroke. And that's crucial for you guys. It looks like a stroke, but it isn't. It's the best thing they can have compared to stroke. It's a chronic subdural hematoma. And that's why you also, and I think nowadays you always should do a CT. If someone has a stroke, always do a CT, because in few cases it's not as common, but in few cases this is a totally different prognosis. And it would be malpractice not to find out that this is a chronic subdural hematoma, because the surgery is very simple. It's in local anesthesia, okay? So what you're going to do when you see this on a CT, and typically over here you have a level, because typically they're laying down. So what they do is, on one side, they just do a small cut through skin. They do a bar hole again, okay, that stays there, and then they do a small cut through the dura. And suddenly the liquid bursts out. And it's like a Coca-Cola, or you could say coffee grain, how the coffee grains look like, okay? So it's like a dark coffee, which gets out. And the point of the surgery is, so over here you do a bar hole, and what you do is you get saline, you just wash it out with sun, and you leave a drain inside, okay, through this small hole. And what's cool about this is that even on a table in a theater, typically, or in few hours, when you do this in a local anesthesia, they start to move. As the pressure decreases, they start to move with their legs or with their one side immediately, okay? Yeah, immediately or in few hours they start to move and talk. If it would be left hemisphere and compression, they could have aphasia and whatever. Suddenly they start to work and be 100% normal again. Okay, so very simple surgery. This could be due to the bridging veins or whatever. Okay, and a fantastic outcome if it's not too long. If you will leave them for long with this hemiparesis, then of course, I mean, the sooner you act, the better. Okay. So crucial thing, crucial difference, and of course on a CT it's dark because it's chronic, it's not acute, okay? So, questions? No questions? Thank you very much, okay? So, thanks for watching, and don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.